Okay, so welcome everyone. Hopefully everyone can see my screen and hear me clearly. My name is Stephanie.
Okay, so what do we...
I am the Executive Director for the New York State Osteopathic Medical Society. Thank you for joining us today, and I hope that you and your families are doing well. This is a critical time, and we wanted to make this presentation available to all osteopathic physicians in the state in hopes that it is helpful in patients as COVID-19 continues to spread. Before we get started, I just wanted to quickly go over a few housekeeping items. Please make sure that you keep your microphone on mute during the presentation so that we don't get any feedback. Towards the end, we will open up the floor for questions. At any point during the presentation, please feel free to use the chat feature to let us know if you do have a question for our speaker, and then we will call on you to unmute yourself and ask your question verbally. You can also just type in your question and we will address them towards the end of the presentation. I will be emailing everyone a post-test and evaluation survey that must be completed within 30 days in order for you to claim your AOA credit for this webinar. We will have the presentation available to rewatch on our website along with the slides, so you can refer back to them as needed. And if you have any questions or concerns following the presentation, please contact us at NYSOMS.org. So without further ado, I would like to introduce and welcome our speaker today. Dr. Richard Chmielewski is an osteopathic physician and the founder and medical director for the Falcon Clinic for Health, Wellness, and Recovery, an osteopathic clinic located in central New York. He graduated in 1976 from the College of Osteopathic Medicine and Surgery in Des Moines, Iowa. He is board certified in emergency medicine, having practiced in central New York hospitals for almost 30 years. He was originally board certified in neuromuscular medicine and osteopathic manipulative medicine in 2006 and remains certified today. He founded his clinic and has been devoted to integrating osteopathic principles into the practice of modern medicine. Additionally, Dr. Chmielewski is a member of the NYSOMS Board of Directors and has been a delegate from New York to the annual AOA convention in Chicago for the last few years. He lectures to the public and periodically conducts training sessions on osteopathic medicine. Adjunct professor
because somebody turned the light.
New England College of Osteopathic Medicine and hosts medical students and residents at his clinic on a regular basis. He is an advocate for implementing osteopathic principles in the area of modern medicine and strongly believes that osteopathic medicine is medicine's best kept secret, but needs to be understood. I will now hand over the virtual microphone to Dr. Chmielewski. Thank you so much.
Hello to my colleagues out there in New York State. Can you all hear me? I hope you can. We just have you, thank you very much for a thumbs up. With that introduction, basically, I want to present to you a different approach to viral respiratory disorders, and specifically something that might be used during this COVID-19 pandemic that we're having.
No matter what I do.
I think somebody there needs to mute their microphone so we don't interrupt on there, please. In 2009, when we had the H1N1 flu, I had gone to Las Vegas and met with a good friend of mine, Dr. Dennis Dowling. And he gave a very interesting presentation on what happened in 1918 during the pandemic at that time. And I was so impressed with that, and I was impressed with the techniques that he showed us, historical techniques that were used, that I started using them in my own osteopathic practice here in central New York. And I'm going to be going over the basic procedures, which we call the influenza protocol from the H1N1 pandemic, but also I think this may also be of value to today with the COVID-19. Now, osteopathic medicine, as you know, really means a lot of things to a lot of people, but there are a number of basic principles in osteopathic medicine. So basically, when I have my students or the public, I tell them that osteopathic medicine, first and foremost, is a philosophy. And I'm actually paraphrasing Andrew Taylor Still, Dr. Still. It's basically a philosophy. And so parts of those philosophy include the idea that circulation is, above all, the major thing that we need for health. And secondly, that structure and function are intimately intertwined, and we are a unit. Additionally, Dr. Still and numbers of people over the last 100 years and so developed a number of different techniques that can be used not only for musculoskeletal problems, but also for different health problems over the years. What I'm referring to is a number of lymphatic techniques that were used, okay? And we normally think of circulation as being the heart, the arterial supply, the capillaries, and the veins. I would actually extend that even further, and again, this is paraphrasing Dr. Still, that there's the forgotten portion of the circulatory system, which is extremely important, and that's the lymphatic system. I don't have to belabor that with you as osteopathic physicians. You remember that from your basic training, and I'm sure you use that in basically everyday life. I ask patients a lot of time is not why are we sick so often, but why are we healthy so often? And one of the answers I give is that it is our immune system. I'm going to be showing you some slides in just a little bit, but I want to just jump ahead with one thing. Just recently now, we have learned that some volunteer patients who had recovered from the COVID-19 are donating their plasma so that the antibodies can be harvested and used in a few patients. And already there have been some positive signs on there. I think it's interesting from 2 points. First of all, this is a technique that was tried back in 1918. And I don't really have much on what the results were then. I'm sure their technology was not as advanced as it is now. But if I can show you today's Wall Street Journal, there was a section here in the op-ed, and they talk about antibodies. Got antibodies? And they're talking specifically about that. Tests show immunity is crucial to beating COVID-19. And this is exactly what I'm talking about. I'm going to show you the techniques that were used back in 1918 and with some modifications there that hopefully you would use on your own patients or however you decide, family and loved ones and so forth. I'm doing this presentation because I'm doing it as a challenge to our medical profession. The osteopathic medical profession has been criticized, I think rightfully so, over the years that there has not been enough research and data to show that what we do helps. On a daily basis, I know it helps, not only musculoskeletal-wise, but the techniques that I've been using for the last 10 to 12 years, I've seen incredible improvements with all kinds of respiratory and viral and bacterial respiratory conditions, whether upper or lower respiratory. So what I'd like to do now is proceed with a slideshow. That slideshow is also going to be on the NYSOMS website. If any of you would like to have a copy of that, go there and download it, or if you wanted to contact falconclinic.com and let us know, we could send that to you. There are a number of slides. I'm not going to go through all of them because a lot of the stuff you already know, and I kind of want to get to the meat of the matter, the reason that we're here. And then after showing you the techniques, as Stephanie said, we're going to open this up to questions.
Okay, so you're going to share screen.
Okay. No. So this is a series of slides that I made. Okay. Now, coronavirus, is there a missing link to treatment? Everybody is talking about the social distancing and personal preventive measures, and I'm totally in favor of that. I think we're on the right track with that. They're also, however, trying to use a different mindset. Vaccines, which are not going to be produced probably for the next 12 to 18 months. People are working on a number of different medications and protocols of medications and so forth. I mentioned the antibody harvesting and so forth. I'm totally in favor of that. And all the supportive treatments, I'm totally in favor of that. But is there a missing link? You have to understand that the osteopathic approach is basically to get the patient into the best physiologic condition using anatomical principles. When you have that, the biological machine is more efficient, it works better. And the immune system and the circulatory system can work better. And that's where we're at. So let's move on here to the next slide here. Disclosure, I have to say, I'm getting no financial remuneration or honorarium. I'm not selling anything. I don't want any payment for this video. If you want to use it and pass it on, I hope you would. Now, what are coronaviruses? Well, it's a family of viruses, and we know that that includes camels, cats, bats, and so forth there. And somebody asked me once, how long has coronavirus been around? I would say it's been around for millions of years, but only recently, for some reason, there were genetic mutations and it skipped over to humans. And there are different subgroups of coronaviruses, most of them causing just mild symptoms. Some of them might just be a runny nose, maybe a conjunctivitis. Lately, we've had some symptoms of people losing their sense of smell. And then it progresses on to more pulmonary diseases. The more important coronaviruses that have attacked human beings were found in the SARS epidemic, that was 2003, and the MERS epidemic, Middle Eastern Respiratory Syndrome, about 2015. The history of the pandemic you know about very well. Basically, we learned about the pandemic in December 2019, and World Health Organization called it a pandemic in March 11th of this year, and it spread throughout the countries. Treatment strategies that we've been using have been basically the preventive measures, personal hygiene, using anything from hand sanitizers to soap and water, which I think is probably one of the best. Social distancing, staying at least 6 feet away, not gathering in large groups of people, self-quarantine, and so forth. We're asked to avoid emergency department and urgent cares. This to me is really important. Our population is suffering with so many different things, not just COVID-19. And as someone once said, pathology doesn't take a vacation during the COVID-19 pandemic. But you have people who are scared. They have a little bit of discomfort in their chest. They're congested. They have a fever. Maybe they don't fulfill the criteria to be admitted, but they're sent home. They go to an urgent care area, and again, the same thing, and they're coughing, runny nose, and maybe high fever. They're told to go home. I understand that, to try to avoid it. But these people are in their homes. They're in their apartments right now, and they are scared. And they say, nobody's taking care of me. What can be done? Well, I would use the CDC guidelines, but I'm trying to tell my osteopathic colleagues that this series of protocol is something that, first of all, might offer hope. And secondly, in the application of this protocol, personally, from my experience over 12 years, I think it may help a lot. It may help to the point that people don't need to be hospitalized. Maybe they don't need to be on a ventilator. Or maybe if they're in the hospital using these protocols, they can be taken off the ventilator and maybe discharged home sooner. That is my hope. And again, I'm going to say we need to have the data. If you're going to do this, I would hope at some point, some of you in the colleges, research, and so forth, would give us the numbers that we need to validate these things. Now, there are a number of treatments that have been tried, and you've seen them on the news there. They tried Ebola medications, vaccines, things for measles, even Lipitor. There are some experimental antiviral drugs like remdesivir, which so far has not had glowing reports. The popular press has talked about Plaquenil, or an anti-malarial drug and also used in lupus, or from a French study, hydrochloroquine with or without azithromycin antibiotic. And those are very small studies. I'm just reviewing on this slide. There was a small report from Marseille, France, 26 patients there. But the study was very poorly done, but yet as people are looking for anything, you're having people stockpiling hydroxychloroquine and azithromycin and so forth. Now, I want to talk about acute respiratory distress syndrome for a second. In 1918, when the patients there had their problems, they succumbed to a number of things that they called pneumonia. And some of them were proven to be pneumococcus and streptococcus and even staphylococcal bacteria and probably a few others. They could isolate those. But actually, a lot of the symptoms seem to follow acute respiratory distress syndrome. Now, acute respiratory distress syndrome, or ARDS, is a breathing failure that can occur in critically ill people. It's not really a specific disease, it's a syndrome. And what happens is you get fluid buildup in the lungs, and basically the alveoli are damaged. Fluid leaks into the blood vessels. Some of the alveoli, they collapse because of lack of surfactant, and the people basically drown in their own secretions. It's a horrible way to go. And it can be associated with sepsis, pancreatitis, trauma, pneumonia, and aspiration, right? In effect, ARDS impairs the lungs' ability to exchange oxygen and carbon dioxide. The primary treatment for that involves mechanical ventilation on there. The syndrome is quite a high death rate of 35 to 50% there. This is a sample of acute respiratory distress syndrome, and you can see the fluffies on the left side in the chest x-ray. A CAT scan that was done on the right shows a severe infiltrate, and this is what is called a ground glass appearance on ARDS. Now, autopsies, you would think, would be done early on so that people would get an idea of what the pathophysiology of COVID-19 is. The problem is, first of all, that COVID-19 being so infectious, there was a great fear of doing autopsies. And to date, there are still not a lot of autopsies done, despite the amount of material that people could work on. You have to have an enclosed environment, negative pressure rooms, you have to have all your PPE equipment, et cetera, and hopefully the pathologist won't cut his finger or her finger there. However, there were, in China, there were 2 patients that were being operated on in February of this year in Wuhan, and their main diagnosis was lung cancer. They were going to do surgery on them, and they started doing the other testing and found out that these people also had some infiltrates and pneumonia, which I'll show you, and they were positive for the virus, for the COVID-19. This really piqued my interest because these were the first early data points, if you will. Okay. Lung damage was noticed with viscous secretions in the air sacs that may explain the drowning sensation reported by patients in severe and critical condition there. There were other organs that may have had some tissue changes, like in the heart, the kidneys, brain, spleen, digestive system. It was mostly the lungs there. So, early changes in the lungs, you can see this one patient here. If you look at their CAT scan, the arrows will show you that ground glass appearance there of pneumonic changes in the one patient that was originally being operated on just for lung cancer, but then tested positive for COVID-19. Over here, you can see the alveolar tissue changes in patient number 1. And I especially bring you over to the B slide, and that shows it's a transudate of fluid in the alveoli. That is the major thing. You're not really finding bacteria there. You are finding clumps of giant cells and other inclusion bodies for virus in the 2 lower slides, C and D. But this really is the fluid, the lack of functioning of the alveoli, and it is consistent with the diagnosis of acute respiratory distress syndrome. This is from patient number 2 that also had a lot of fluid and cellular debris, especially in slide A. And you had proliferation of numbers of white blood cells in D, and also some giant cells and cellular proliferation and fluid in slide C. This is a slide that we use to show the pathophysiology of acute respiratory distress syndrome. And when I saw this, I said to myself, this is not complete. There's something going on here. What is the missing link? On the left side of this slide, the artist's rendition, you're going to see a nice alveolus, and occasionally you have some white blood cells checking things out and so forth. You have a nice arteriolar supply of blood with the red blood cells coming in, and then you have the exchange of gases and so forth. But then if you have problems with inflammation over on the right side with an injured alveolus, what happens is you have a number of different types of white blood cells, multinucleated white blood cells coming in. You see fibrin as well coming in, all right? And then you're seeing all these different cytokines. Well, I looked at this and said, not complete, there's something missing, okay? And what is that missing thing, okay? So the lymphatic system at a tissue level shows the supply side, the arteriole, going through a capillary to the vein. But the lymphatic system is extremely important in this whole process. And lymph vessels, they drain excess extracellular fluid and transport antigens as well as immune cells to lymph nodes so they can filter out the body fluids. That completes the circuit, so you have a closed system in the circulation. Especially in the lung, fluid balance and efficient immune reactions are essential because accumulation of fluid as well as failure to fight infection will lead to impairment of gas exchange and ultimately death. And that is the main pathophysiology of that. I won't belabor the Starling equation, but you know yourself, you're supposed to have a balance between fluid going out of the capillary and coming back in the venous side on there. But even that's not a complete system because some of the proteins and fluid will get out into the tissues, whether it's in a leg or in this case around the alveoli. And that has to be taken care of by what I call the sewer system. If that sewer system backs up, what happens is fluid accumulates outside of the capillaries and it has to go somewhere, and it will eventually go back into the alveoli, and the exchange of gases will stop. So applying this Starling's law to the alveoli and the capillaries, again, if you just look at it, you have blood coming in and blood going out. And the thing I like about this is that you have the fluid in the right middle side showing that excess fluid is supposed to go into the lymphatic system. Now, the lymphatic system of the lungs, very quickly, you have on the microscopic level, you have the alveoli coming together in these small lymphatic tissues, and then they drain either into the right jugular vein or the left jugular vein. Now, that's going to be important for part of the influenza protocol. I'm going to be talking about the right and left internal jugular veins shortly. The other thing is, coming from the lower parts of the body and the chest area and the abdomen, you have the thoracic duct. And the thoracic duct on the from the legs and the abdomen and the left arm drains into the left jugular, internal jugular vein and subclavian veins. The right arm and the head and neck drains into the right internal jugular and right subclavian vein. And that's going to be important when we talk about rib raising, okay, and compression on the chest, because if you look at a lot of these little lymph areas here, they overlie the heads of the ribs, okay? You can think of it as a sandwich. You've got a rib, then you have the lymphatics there, and then you have the pleura, okay, on top of that. So if you're raising those ribs, you're kind of squeezing or massaging those lymph tissues as they propel with one-way valves up into the jugular veins there. So this is really the complete circuit. Lymphatic circulation of the alveoli shows that you have the arterial supply and then the venous return, but intimately you have the lymphatic system hooked up with it, okay? So pulmonary changes in the COVID-19 Chinese autopsy reports showed that there was fluid exudate in the alveoli, okay? The other thing, fibrin products were in the alveoli. There are research papers that show when you slow down the flow, okay, of the blood in the capillaries there, that fibrin is deposited in the tissues, and in this case, even in the alveoli, okay? So you have slowing of the capillary circulation. Is this a trigger that causes fibrin deposits to be released into the alveoli? Because you have to remember that not only do you get hypoxic changes, you get poor gas exchange, you get fluid in the alveoli, eventually you get an element of DIC, and the fibrin products are basically used up because all over through the body you get microclotting. And that's one of the reasons not only do the near terminal patients turn blue or cyanotic, but also many times they will start to bleed from different areas. And this is one of the reasons, I feel, because of the slowing of the capillary circulation, okay? And this shows an example of that. Reduced flow promotes fibrin deposition, and that's from an NIH paper. Now, most of the slides that I'm going to be showing are as a result of my good friend, Dr. Dennis Dowling, who in 2009 showed the influenza protocol first. So why the osteopathic approach, okay, to our present COVID-19 pandemic? I think you already kind of know the answer to that, okay? A lot of people died in 1918. And this is from a paper in Vietnam from 2004, said, supportive care may be the only option available. Even if more effective standard pharmaceutical treatments are produced, it is unlikely that sufficient quantities will be rapidly or widely available because of financial, logistic, and healthcare delivery limitations. So what we're talking about is everything from mask, glove, ventilators, even antibody harvesting, and so forth, as well as personnel. If it keeps going the way it is, we need to have supportive care, all right? And one of those things I feel is to improve the physiology of the human body, to hopefully see if it can heal, okay? So what about osteopathy is one of those things there. Okay, Dr. Andrew Taylor Still, we know about him, and he said back 100 years ago, I have successfully treated many cases of pneumonia, both lobar and pleurotic, by convecting the ribs at their spinal articulations, and I carefully adjusted misplaced ribs, okay? The osteopathic prognosis for speedy relief in influenza is good when the osteopath has been called to the case within a reasonable time. So what I'm saying is this could and should be used earlier rather than later. This should not be a final resort on there. So there are a number of different slides on there, but one of these that I thought quite interesting. 100,000 cases of influenza with a death rate 1/40th of that officially reported under conventional medical treatment. And that was published in 1920 in the Journal of the American Osteopathic Association. 1/40th the mortality rate of patients treated by MDs. I think that's a number we have to look at, okay? That's why I'm asking about. And I've got a number of different things. I don't want to belabor this, okay? But we're going to be showing some things here, okay? So what should we do? Use OMT. It's time to roll up our sleeves, vaccinate patients, maybe do the antibody treatments, find some other things, and hone our osteopathic skills. So with that, what I'd like to do is I would like to ask my wife, Paula Chmielewski, if she would be our patient, okay? And I'm going to show you the basic influenza protocol, which is in the NYSOMS site. And then I'm going to go back and just show you a couple of nuances. Now, in her case, if she's not coughing, doesn't have a fever, okay, it still might be a good idea for maybe for her to have a mask. She doesn't have to have one. But if there was something like that, or obviously if you are in an intensive care setting, you should have PPE. I'm only having this here just to remind you that we, you know, if there's any suggestion of fever, cough, and so forth, at least the patient should have the mask. You should probably have one. If you're intensive care, of course you could. And I'm just showing you this. I'm not going to put it on because I don't want to muffle my voice. All right. So I have the patient here, and Paula, if you could turn to the side, okay. With females, but a lot of times with males too, I'll do this. Paula, can you cup your breasts? Okay, she's turned away from me. And what I'm going to do is I ask permission. I can put my hands over there. Okay, have her permission or consent. And what I'm going to do is I'm going to have you take some slow, deep breaths in and out. Deep breath and let it out. And I'm going to follow her down, a little pressure. As she takes a breath, I'm going to ease up, but I'm still going to be doing what I call suckusation. In other words, kind of jiggling any secretions and so forth, okay, to loosen things up so that she can cough. And a lot of times when you do that, take a breath, the patient will cough, okay, and let it out. And now when she takes another breath, I'm going to hold it down for a little bit and then release it, like releasing a cork in the bottle. Take a deep breath, and I let go. And patients a lot of times will cough, expressing fluid. I usually like to do this a couple of times, okay? So again, deep breath and let it out. Take a nice deep breath in, let it out. And you get the idea on there. Then she'll take another deep breath. And as she's breathing in, I'm holding down and then I let it go, okay? Now, do you remember the internal jugular veins here? Okay, what I'm going to do is what's called a J maneuver. I'm going to be basically massaging the lymphatic and venous drainage from around the head area over to the jugular veins. I call this the J maneuver here, okay? So I'm going down and across the upper part of the clavicle this way here. Here, down, and to the side. Down and to the side. I'll do that 5 or 6 times. And then I will go to the posterior lymph chain, and I'll either use my thumb and do a J maneuver, or I can use the side of my hand here and go down and to the side, down and to the side, like that. And I'll do that 5 or 6 times. And then I'll do the same thing on the other side here. Okay, down by this sternocleidomastoid muscle and the external jugular vein and the lymphatics with the J maneuver, and again, the posterior ones, or I may use my hands like this, okay? Another thing that I will do is, a lot of times people have congestion up through here. I will start at the forehead area, right near the glabella here, and I'll go on the sides of the sinuses down to the tragus, okay, the front of the ear. And I'll do that a few times. And I'll go down over here by the, just below the orbit here, okay, and below the maxilla. And I'm using more of my tip of my finger and then to my side of my thumb. So starting tips of fingers and then flattening as I go to the ear here. And I'll do that about 5 or 6 times. Then I will do a tapping maneuver. This is similar to that succusation or the breakup of the mucus that I did over in the lungs there, okay? And I'll do that a bit. Same thing down here in the, okay, in the infraorbital area, okay? And then again, I'll massage that a little bit, and then over here as well, okay? So that'll help the drainage from up here, okay, into what I call the central core, which we just did. Now, the next thing here is to go to the abdomen and check and make sure that there's no contraindication to that. Do they have a large spleen? Is there a lot of pain? Hopefully there's not any kind of a rib fracture or anything like that. Is there any pain through there? Okay. So what I'm going to do here is I'm going to have one hand back here, one on top of the rib cage. This is the costal margin right here. I'm going to have my hand on the lower ribs and one here. Instead of just going up and down, I'm going to be going in a 45-degree angle because the ribs go kind of up and down a little bit, okay? So this hand is going to go this way, and the one down here is going to go up. It's going to be this kind of a maneuver. And so about 2 times a second, okay? Like this, 1001, 1002, 1003, like that. You don't have to count, but I mean, you get the idea, okay? This is called a liver pump, okay? The liver being a filter, okay, and part of the immune system, it has its own reticular endothelial system, but it also sequesters millions and millions of white blood cells. And it's been shown that by doing this liver pump, you are getting millions of white blood cells out into the general circulation. So I'll do this maybe 60 or 80 pumps on there. Now we'll go over to the other side where the liver is, I'm sorry, the spleen, and I'll do the same kind of a thing. One hand underneath, another hand on top, and I'm using that maneuver again with the upper hand going down towards, caudad towards the feet, okay? And again, it's about 2 times a second on there. The spleen, as you all know, is a filter, and it also sequesters millions of white blood cells. And it has been shown in humans who were treated this way for pneumonia that you sometimes even doubled their white blood cell count by doing this very simple maneuver here, okay? So I'll do that maybe about 60 times, okay? We come down to the legs here, and I want to do a little bit of what's called effleurage, going from the ankles up to the thigh on both sides. And this gives a signal to kind of relax the muscles to open up the lymphatic and venous drainage again to the central core, okay? And I'll do that, I don't know, maybe 9, 10, 11 times on both sides. Finally, I will come here and do what's called a pedal pump or Dalrymple's pedal pump. And again, 2 times a second. What I'm doing is I'm stretching the muscles of the legs and improving venous return from the feet, lower legs, and the thighs up to the abdomen. Now, if you look at the abdomen, I'm also jiggling that abdomen, all right? This is very important. When you jiggle the abdomen, the intestines, they have what's called GALT tissue, gastrointestinal associated lymphoid tissue, GALT. Now those white blood cells, they're like commandos. They have been fighting bacteria to keep it in the intestinal lumen all the time, all right? By doing this maneuver, I'm getting some of those commandos, some of those GALT white blood cells into the general circulation. I'm also augmenting the liver and spleen massage with this technique as well, because the intestinal contents massage the liver and the spleen. The other thing is, people who are coughing quite a bit, you know, the diaphragm is a muscle. It can get tired too. And if you do this technique here, you're also massaging the diaphragm. Okay? And that is the basic influenza protocol that was used. Now, I didn't have a timer here, but it probably takes about 5 minutes to do it. We do it here in the clinic. Brianna, our nurse, she has been trained and she does it as well. What I want to do is I want to show you just a couple of nuances of things that you could do as an osteopathic physician, because you're more trained than the average physician in doing different things. One of the things, once you've been doing some of these techniques for the head and the neck, is a simple suboccipital release, okay, and condylar spread. What I mean by that is you're taking your fingers and you're pushing up in the suboccipital area a little bit, drawing it towards you a little bit, and then spreading your hands out a little bit, okay, along the occipital condyles. What I like to do is with my little fingers, I even stretch out the rectus capitis oblique muscle that you feel on the sides there. And it's a very simple thing, okay? I simply lift up with my fingers, pull back towards me a little bit. I'll hold that for a few seconds, and I'll start the spread a little bit, and then with my fingers, get that rectus muscle there, okay? Another technique for people who are having inflammation and so forth, especially in the ears on there, is the gall breath technique. And for that, you need to take your fingers over by the angle of the jaw, and then with your thumb, circle around the jaw. Can you open your mouth just a little bit and relax it there? And what you're doing is you're pulling up with your fingers on the angle, and at the same time with your hand, you're going this way. So the maneuver is like this, okay? Okay, with the mouth being the center, okay, as you go. So and you're basically stabilizing the head here. And so that will, you just do this gently, like that, again, 2 times a second. And you might do that for a set of 10 and relax. And you might do that again. Well, open your mouth just here, thank you. Just like that, okay? And then you might do the other side, all right? Another thing that can be done is opening up the thoracic outlet here. And those of you who know the myofascial release techniques, I take my thumbs and put them underneath, my hands here, and I'm looking for a balance point. So I'm going to basically push down and up on either side and see where's the point of ease. And for her, it's on her left side here, okay? So I'm going to push down. Actually, in your screen, it looks like the right side. And then the other thing I'm checking to see rotation, and she likes to go down and rotate that one way, okay? And then forward or back, and she wants to go forward. So she wants to go down, rotate and down, and I'm just gonna hold that there lightly. There's not a lot of pressure, is there? Yeah, it's very light, and it might take maybe, I don't know, 5, 6, 8, 10 seconds, and see it loosen right up there for me, okay? That opens up that thoracic outlet. Now, I mentioned the thoracic duct and the lymphatic channels along the ribs there in the slide. You can reach those areas a number of ways. One way you do that is to get your hands underneath the ribs, so you're next to the vertebral column. And I start up on top, all right? And I lift my fingers up, back towards me a little bit, and down. I go back again up, get the paravertebral muscles towards me a little bit gently, and down. And I'll do that rhythmic motion a few times, maybe 4 or 5 times. And I will have a colleague on the other side doing the same thing, okay? And then we go down 4 vertebrae, and we do the same thing, okay? Like that, okay? And then we go down 4 vertebrae and do that again. Now, if you're alone or it's difficult to do that for whatever reason, can I have you turn on the left side for me? Bend your knees low. I can also have the patient where I stabilize their shoulder. Here's the spine here, and I'm right next to it. And with my fingers, I'm going to just kind of gently dig in and pull towards me, and then just move that shoulder away or rotate it a little bit, because I'm springing the ribs right there, just like I did when she was laying down. And I'll go down and I'll do the same thing there, like that, maybe 4, 5, 6 times, okay? And I'll go down a little bit more, okay? And I'll do it that way, okay? And I know you all have variations on these, but these are the rib raising techniques. Okay, thank you. So, so I gave you in my introduction my reason for wanting to do this and why I was so impressed with this whole thing. We went through the slideshow, which you have on NYSOMS. I went through the influenza protocol, which you can get on the NYSOMS site or the falconclinic.com website. And then I went through some variations or nuances of that. And I'm sure you have a lot more too. As osteopathic physicians, you might have a number of different techniques there. There's the Plowman maneuver inside the neck to move the vomer up and down, to open up the sinuses and so forth. And I'm sure you will look them up or use them or share them with your colleagues. And so, Stephanie, I'd like to turn this back over to you now.
Thank you so much, Dr. Chmielewski. That was great. We're going to open up the floor now for questions. If you'd like to ask a question, you can type it into the chat box, or if you'd like to ask a question verbally, please let me know, and you know, we'll call on you to unmute yourself so that you can ask that question. So, any questions? We're getting some good feedback in the chat, so that's good to hear. Okay, so we have a question from Beth Hayes. Can you adjust techniques for hypoxic patients that cannot lay flat?
Sure. Obviously, if somebody's hypoxic, they're probably going to be flat. But you're talking somebody who has difficulty laying down. Can something be done with them, let's say, in a sitting position? Is that what you're asking? Because I'm going to show you a technique there. And in fact, this is one technique that I actually do quite a bit. I have the person sitting such that their feet are flat on the floor. And I have the person then hold their wrists like this and bring their arms up. I don't want to be stepping on their foot. And I bring my hands back and I have them take a deep breath as they come forward. Can you see that? Yeah. Okay. Deep breath in, let it out. And I slowly bring my hands up. I'm also going to ask Paula if she would also go on the other side so you can see this. Okay? No, you're okay. Don't say, can you turn around the other way? Over here. Yep. So again, not to step on your feet. Okay? I try to get down as far as I can here, and I'm going to be walking up this way. So take a deep breath, and we're bringing these up. See? Deep breath. I'm pushing in. See? Like that. I'm pushing in. And I got to the top. I'm pushing in. Now, Rihanna, if you can show, another thing that I'm doing is, as I'm doing this, show the shoulders. I'm also bringing the ribs up a little bit. I'm spreading my elbows out a little bit, if you back away. So like this. Okay? So the person's, they're lifting their own ribs up like that. So it's a seesaw maneuver. Thank you. I hope that answers that question. That's one of the techniques. And I'm sure as time goes on, you will figure out the geometry yourself based on how big the patient is, how big or little you are, or how strong you are, or how not strong you are. You can work around that. I hope that answers that question.
Okay, great, thank you. And we have another question from, let's see, Dr. Balthazar. Would lymph pump be considered a spreading event?
Would what?
Would lymph pump be considered a spreading event?
A spreading of what? I don't understand. I'm not sure what the question.
Dr. Balthazar, if you wanted to unmute yourself, you're welcome to do so if you wanted to get in more detail with your question. Let's see. Lots of good feedback. Okay, here's another question from Jared Dropkin. What about the potential of aerosolizing the virus during pumps?
Absolutely. You know, in fact, that's, yes, that's a very good question. And that's one of the reasons, first of all, that you have the person have their head to the side. Secondly, for people who do have any kind of a cough, even if it's a dry cough or productive cough, they definitely should be wearing a mask. If they're in the hospital, or if there's any question in your mind on there, definitely should be wearing at least a mask. You notice, I mean, I have my jacket here, and that goes. That's going to go into the wash here shortly. The other thing is, when you say aerosol, you got to remember, at least from what we know, that the virus is basically in the sputum and secretions and so forth. And as it's coughed out, these things, according to what we know, drops down, okay? And they don't live very long. They're not very strong viruses, okay, contrary to what people think. But it's not like feathers, you know, where you blow it out into the air and they just stay there like that. Okay. Now, if somebody coughed at you and you walked into that spray, of course you're going to get hit with the droplets. That's why you stay away from that, why you clean surfaces, why we have the masks, or in people who would have fever, things like that, they should have the PPE equipment. But it's my understanding from everything that they've said through the CDC and scientists, these things do not just linger and float like dust particles in the air and the sunlight. They're in this secretions, and they drop down fairly quickly.
Great, thank you. Dr. Balthazar, did you want to ask your question? I see you unmuted yourself.
Can you guys hear me at all?
Yes.
Yeah, great. So I was asking the same question about aerosolization. One of the big issues that we're having here in inpatient is that anything that can cause aerosolization, CPR even, is considered a spreading event, or CPR is super spreading event. So the idea of doing anything that might cause any amount of aerosolization is going to prohibit or be pushed back against by the administrators or anyone really, because they're not familiar with the technique. So do we have any research or any background that can say about the amount of aerosolization that can occur, not necessarily with COVID, but other things with the lymphatic pumps? Because this is something I want to bring, but I need to be very clear when we're approaching this, if there is increased risk. And should we be using full super spreader type, meaning full gear, when you're doing a lymphatic pump, or do we just take out lymphatic pump entirely as a potential cause of exposure?
Believe me, I share your concerns on that. And that's why, again, the best thing I can tell you is two basic things. First of all, I know about them kind of holding back on the CPR. However, just about anything that you do, even turning a patient over and then exhaling, things like that, is going to actually even talking. Some people, they talk and stuff gets out. But anyway, in a hospital setting on there, there is going to be some level of exhalation, if you will, or expectoration of virus particles. And that's why, obviously, those people at least need to have a mask. And if there's any concern, yes, you need to have the proper PPE equipment and a gown. Now, if you remember what Dr. Still said early on, and what we also know from that one Vietnamese paper, that these techniques can be used on any patient with the proper precautions. But like anything else, if you do them early on before they're even on a ventilator and in the intensive care unit, my hope is that by doing these things and with the proper hygienic precautions, that I'm hoping a lot of these patients will not even end up on the ventilator in the first place. Now, the other thing is, if the ARDS approach and the lymphatic theme is correct, I would love to see the numbers. I think sometimes you have to take a chance. These people are dying. I mean, they're having at least a 50 and more percent, 75 in one study, percent mortality rate, okay? You're talking about aerosolization. Believe me, I understand that for the healthcare workers. But if you can increase the chance of survival, I think it's worth, I guess you want to call it a chance. It's worth a chance, but a hygienic chance.
I don't think the question, my question isn't geared towards should we protect ourselves or not, is do we have any research background that I can use to support the larger scale use of OMT? Because I'm trying to push for OMT research on COVID patients, and I have I have all the stuff you put up as well, and I would love to get the slides too, by the way, to try and bolster this research proposal. But if we don't have anything to back up lymphatic pump as yes or no, and it does resemble to some people things like compressions and CPR, it's going to be more of a challenge to include that particular thing in the protocol.
Well, actually, there are some things there. I can answer that. Lisa Hodge down in Texas, she's a researcher, and using animals has talked about lymphatic flow using thoracic pumping techniques. That's one thing. If you look at the slides that I have there from the influenza pandemic, there were papers talking about the spleen and the liver pumps on there. But aside from that, there's been a lot of research in the effectiveness of various osteopathic techniques, especially in the last 15 years. It's just blossomed. Having said that, I think it's sometimes to our own detriment that we become timid in trying to think outside of the box. My answer to that is there is no box. Now let me finish. What about these other studies? You've got like a few people in Marseille, who had hydroxychloroquine and azithromycin, and all of a sudden the rest of the world is jumping on that. You look at some of these cancer studies for lung cancer to increase the survival rate by 6 months. There was one study, there were like 6 patients on there. And what happened? Now you have all these people using that drug in cancer. I'm not saying we shouldn't have double-blinded studies. I'm not saying we shouldn't have more data. That's exactly what I'm saying. But at the same time, if we really do have a pandemic, if we're in a war situation, and our other colleagues, MD and DO, are using small numbers to come through with a big generalization, I think that we can step into that fray as well. And we can say, all right, you guys are just working on surmising something. What I'm telling you is these studies were used in 1918 and were looked at, and they were published in the 1920s and 30s, and they showed 1/40th the mortality. I think that's got to be looked into. I think that has at least as much validity as these little studies that have 6 patients. That's all I'm saying.
I agree with you 100%.
Well, you don't have to agree with me, but thank you. Thank you for your interest and your question. And I wish you the best.
Okay, let's see. We have a lot of questions coming in. There's a lot of great discussion in the chat. I guess we can try to answer maybe 1 or 2 more questions, and then whatever questions we don't answer today, please email us, and we'll make sure that we get those to Dr. Chmielewski, and he can answer those via email. Okay, just looking at the chat real quick. Someone asked, can you demonstrate the Vomer pump that was mentioned?
Okay. If you want to lay down. Okay. The Vomer pump, or it's also called Plowman's maneuver. I think the fellow's name was probably Plowman. And if you look at your anatomy, the hard palate of the mouth, I'm using a glove here, as you can see. The nasal chambers are separated by the vomer. The vomer then hooks up with the ethmoid bone here. So if I have my finger here on the middle of the hard palate, I call it right about where our peanut butter sticks. You know, you eat some peanut butter, it'll get up there in your mouth, right on the roof of the mouth. That's where the finger goes. And you're doing a rhythmic pushing maneuver up towards the glabella here, okay? And you can tell that you're moving that vomer back and forth and rocking the ethmoid, because you can even feel a little bit of movement here. So Paula, could you open just a little bit? Okay. And so I'm going to be pressing up towards your head and towards this point here, just back and forth until I feel right about there. And you can feel the movement up and down a little bit. And again, about 2 times a second. And I'll do this about maybe 20 times and relax. What that does is that rocks the ethmoid there and opens up the different ostia there so that they'll get drainage from these sinuses down into the nose there. And it's a very effective technique. I hope that answers that.
Great. And okay, we have, let's see, one more question here. Is there a reference available for the statement that the spleen maneuver doubles the white blood cell count?
Yes. If you look in the slide presentation, there are some cases there. And again, this goes back to, I can't remember the date of the paper. I think it's in the mid-20s, the 1920s there, where they were doing the maneuvers there. And they actually showed some increase in white blood cell count, and I think a few other elements there in the blood. Okay, so check on that slideshow.
Okay, any other last minute questions? Okay.
Stephanie, if I could interrupt.
Sure.
Is there a way that maybe even some of those questions could be, let's say, put on the NYSOMS website, and possibly some of our participants here might even be able to at least give their opinion, or maybe they might have some answers through their own research?
Yes, definitely. We can even set up some sort of a chat or something on our website where people can ask questions and everyone can see them and answer, and have sort of like a discussion board. I'm happy to work on that and put something up on our website that everyone can access, and then I can definitely send the link out to everyone that participated today and those that weren't able to. And we can definitely put up these questions as well and start a discussion on our website for sure.
Okay. And I really want to thank all my colleagues, you know, for at least having the interest in this. And please understand, I'm not saying that I have a cure for this, okay? And I'm not saying it's the best thing that's going to happen, but it was one of the major things that happened in 1918. And I'm challenging the osteopathic medical community. Look at this stuff, okay? And if you have questions, See if we can get some data. I'm challenging the osteopathic profession, the principals, either prove or disprove this. Now's the time we can do it. Thank you.
Okay, thank you so much again. Thank you to all of you. Let's see, I just wanted to share one more thing with you all. Okay, let's see. Hopefully everyone can see my screen now. I just wanted to thank you all for joining us. I hope this was helpful and you're taking away some good tidbits and information from the session. Thank you to Dr. Chmielewski for being our speaker today and working with us. Some of you were asking about the slides and recording. Yes, we're gonna have that available. Give us a day or two. I know it has to download and then we have to upload it. So we will let you know when that is available on our site. And please make sure to complete your post-presentation survey. You'll get an email in the next couple of days. Complete that. Any questions that weren't answered today, email us at nysoms@nysoms.org. Visit our website. We have a great resource page for COVID-19 resources, updates. You know, you can find out more information how you can get involved with NYSOMS. Consider becoming a member. We would love to put on more webinars like this in the future. So if you enjoyed this today, send us an email. I want to hear your feedback so that we can design and put together more webinars like this for the future. So that's it. That concludes our presentation. Thank you all. Stay safe and please reach out to us if you need anything. Thank you.